It's lovely to be here in Montreal to talk a bit about the work that we've been doing over the last little while. And it's been great to be a part of this first and hopefully first of many sessions looking at the interrelation between HIV and cannabis. I started training as an HIV epidemiologist. Obviously that didn't go too well, and now I'm more working in the substance use field. But I think for all of the speakers today, we would agree that it's a very exciting time, both in the United States and Canada, to be doing cannabis work. And I've certainly learned a lot from the speakers that have preceded me today. I'll try to live up to their very high standards. Unlike them, I'm not a real scientist nor a clinician, but I'm an epidemiologist, and I'll talk a bit about the work that we're doing in Vancouver. Before I get there, I should share with you my disclosures. I'm supported by NIH, CIHR, and Michael Smith, which is a Government of BC health funder. And since January 1st, I have been the UBC's first inaugural Canopy Growth Professor of Cannabis Science, which is a title I'm still getting used to. But rest assured, I have no personal financial relationships with the cannabis industry. I also want to acknowledge the fact that my work takes place on the unceded territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. And I also want to recognize activists, some of whom are in the crowd, many of whom over the years have been living with HIV, who are really responsible for where we're at today in terms of having a public health system for cannabis, and as well to be able to do this kind of work as well. So I recognize them at the same time. Moving right along. Unfortunately, I probably don't have to remind anyone in the crowd that we are living through a public health catastrophe. And indeed, in the United States and Canada, this is the worst public health catastrophe, I would argue, since the worst days of the HIV pandemic in the 1980s and 1990s. In my province of British Columbia, we have lost thousands of our fellow citizens to drug overdoses in the last number of years. And this, unfortunately, is a pattern that has been repeated in many other jurisdictions across the United States and Canada. 2018 was the fourth year in a row in which we saw unprecedented numbers of deaths from drug overdoses in the province of British Columbia. The causes for this are really multifactorial, and I won't go into too much detail, but they should be well known to many. In this country, in the United States, we prescribe too many opioid analgesics. There are too many people, unfortunately, living with chronic pain. And most recently, our illicit drug supply has become contaminated with fentanyl, which is a novel opioid analog. The good news, of course, is that there are evidence-based interventions to address this crisis, to not only lower the risk of overdose for people who use drugs, but also to lower the likelihood that those experiencing an overdose will die. Things like opioid agonist therapy, peer-distributed naloxone, and supervised consumption facilities have all been shown to have very beneficial effects on the likelihood of opioid overdose. However, unfortunately, they are largely out of reach to people who need them across the United States and Canada. In the United States, for example, opioid agonist therapy is typically only available through doctors' offices, and studies have shown that dosing is typically not high enough to assure optimal outcomes. Here in Canada, although the first supervised injection facility opened in Vancouver in 2003, there are still only a handful of these sites across the country, despite clear evidence that they save lives and prevent further HIV infections. So there is clearly a need then for us to develop, test, and scale up new interventions that will save the lives of people at risk of overdose. Many of us, of course, are very optimistic, and we're very interested by this paper, which came out in 2014 by Marcus Bachhuber and his colleagues, which showed, in a longitudinal analysis, a beneficial relationship between having a state-level medical cannabis regime in the United States and lower levels of opioid overdose mortality. In fact, in a longitudinal model, they found that states with some sort of licit access to medical cannabis had approximately 25% lower rates of opioid overdoses than states that lacked some sort of licit access to medical cannabis. Now, I would be an even more mediocre epidemiologist, of course, if I did not point out that this is an ecological analysis. This is not an individual level analysis. However, it is one of a number of studies which have found these interesting associations between legalized or reformed licit access to cannabis and lower rates of important opioid-related outcomes. So, for example, the last bar on the right there, I can never tell my left from my right, shows 25% lower rates of opioid overdose for states with licit access. States with that licit access also have lower rates or lower levels of opioid prescriptions, lower amounts of dispensations of opioid analgesics, and lower rates of opioid-related hospitalizations. Now, as I said, these were ecological analyses, and they could be the result of things not related to cannabis at all. For example, maybe differences in incarceration patterns, differences in underlying prevalence of pain, and the like. However, as we've heard from the previous speakers, there's a tremendous amount of plausibility about the physical and psychological impacts of cannabis and cannabinoids. Another advantage, of course, of going last is that many of the speakers have already covered this background, so I won't get into too much detail. We know, of course, that cannabinoids interact with the body's endocannabinoid system, and there are increasing amounts of preclinical findings which implicate the endocannabinoid system in the regulation of processes that are central to the creation and maintenance of addiction. Things like pain, memory, and craving and withdrawal have all been shown to be implicated in the endocannabinoid system in humans. And we're even beginning to see the ability to manipulate addiction-related process through controlled exposure to endocannabinoids, phytocannabinoids, excuse me. This is a great paper by Yasmin Hurd and Didier Jutra-Aswad, who works here in Montreal, who are looking at cannabidiol, CBD, which of course, as you now know, is the cure for everything, according to Gwyneth Paltrow and her friends. I was in Los Angeles recently and was told that I could get CBD in my latte. I did not do that. However, they did, in this study, look at the effects of high doses of CBD among people who were abstinent heroin users. I'm not a licensed psychologist, so I won't get into too much detail. Suffice it to say, what they found was that individuals who were randomly assigned to receive CBD had blunted craving, both immediate and 7 days after, when presented with a visual cue for heroin use. So, let me summarize. We have good ecological evidence suggesting that there's some sort of beneficial relationship between cannabis legalization and measures of opioid exposures and harms. We also have preliminary data, preclinical data, as well as experimental data in humans, which supports the hypothesis that cannabis or cannabinoids could have a beneficial role for substance use disorder, and as well for many of the prevalent co-morbidities that often go along with substance use disorder, things like pain and trauma. What we need now, scientifically, are individual level analyses among people at the highest risk of overdose to try and better understand in real world scenarios the relationship between using cannabis and the risk of overdose. So that's what I'd like to do today for the remainder of the time that we have together. And what I'm going to do is use data from the studies that we've been running in Vancouver involving people who use drugs. And we've been working with these folks in some cases all the way back to 1996. These are 3 studies. They're each community recruited studies. They involve slightly different groups of people who use drugs in Vancouver. They have been, since '96, funded by NIDA, and they use sort of harmonized measures to allow us, when appropriate, to analyze things all together. So we have, the first study is VIDUS, the Vancouver Injection Drug Users Study, which has been going on since 1996, and it began as an investigation of the HIV outbreak, which began in Vancouver in the mid-1990s. That includes HIV-negative adults who inject drugs. The at-risk youth study was begun in 2005. It includes street-involved youth, so either youth who are outright homeless, living in shelters, or couch surfing, who use drugs. And then the best cohort, well, it's my cohort, so I'm not sure if it's the best, but I'm going to say that anyways, is Access, which is approximately 1,100 people who are living with HIV and who use drugs. And I should specify that the eligibility for all of these studies require individuals to be drug users. However, we do not count cannabis to be a drug. So primarily what this means is that individuals are smoking crack cocaine, injecting cocaine, injecting heroin, or injecting methamphetamine. As I said, the studies all work the same to allow us to analyze things all together when necessary. What we do is we recruit individuals from community settings, from the downtown east side area of Vancouver, which if you've ever been there, you know it's a very marginalized, poor area with a high degree of illicit drug use. At baseline and every 6 months, we interview participants, and we also perform an examination which gathers blood and urine for disease monitoring purposes for HIV positives and for antibody testing for HIV negatives and HCV negatives. Since 2015, we have also gathered urine for urine drug screens, so another measure of exposure to drugs. The real heart of the matter, though, is the interview process, which can often last for a couple of hours, in which individuals respond to a trained interviewer, and we elicit data on their sociodemographics, their lifetime and recent drug use, their healthcare access, their exposure to the criminal justice system, really anything we think has an important influence on their health and well-being. That's what we're gathering through the interview process. Over the years, we've recruited more than 3,500 individuals. We've gathered more than 20,000 longitudinal interviews, almost 100,000 biospecimens, and it really is one of the largest and longest studies of drug users in the world. So what have we learned about drug use and about cannabis use in particular? The first thing to know, of course, is that cannabis, in this group, cannabis use is very prevalent. And let me sort of pause there to really emphasize that this is, although you've probably gathered that by now, this is not a sample of the general population. These are individuals who are living with very high rates of substance use disorder, who are marginalized. Approximately 75% are either homeless or living in very poor housing conditions. They're also the survivors of tremendous amounts of physical and psychological trauma. The HIV prevalence in this group is approximately 25%, and consistent with the sorry history of Canada, a large proportion of these individuals are Indigenous. So back to cannabis use. It is very prevalent in this group. In the last 6 months, at the most recent interview period, more than a majority reported that they used cannabis, and among those, approximately 40% told us that they smoke cannabis every day. As other speakers have noted, the intentions, the reasons for cannabis use vary, and what I'm presenting here is any intention in the middle column is there, and then the most important intention is the right-hand column. So obviously you can see that the recreational reasons to get high or socialize is the predominant reason people are using cannabis, both in terms of any use and in terms of the most important use. But I would also point out that approximately 75% of the individuals in the cohort report some sort of intentionality, therapeutic intentionality. They're using cannabis to relieve pain, to help with sleep, to substitute for other substances, to help with sleep or to treat nausea or lack of appetite. So the therapeutic use of cannabis in this setting or among these individuals is very prevalent. Substitution was really the first thing that we were quite interested in looking at. And we began by asking people if in the last 6 months, if they had used cannabis as a means of slowing down or reducing or controlling their use of any other substance. And many of us thought, well, yes, well, you know, the people who say yes to that, they're going to tell us that they're using cannabis instead of opioids. We hypothesized, you know, similar analgesic properties, anti-anxiety properties. So it was quite a surprise when we found at the first cut of the data that indeed the most common substance people were substituting for with cannabis was crack cocaine. Of all the reports of substitution, more than half said that they were using cannabis to substitute for crack cocaine. In second place was injection heroin, and in third place was injection cocaine. Things became even more interesting when we aggregated those responses and we looked at the frequencies of crack cocaine use. among those individuals who said that they were substituting cannabis for crack. So if you look at the top, the blue bars, and they are divided into crack frequency before, during, and after someone reported that they were trying to control their use of crack with cannabis. And I think you can see just visually that there is a substantial decrease in the frequency of crack cocaine use compared to the before and during period in the after period. And this apparent difference, visual difference, was in fact seen as well in the longitudinal statistical models that we built to try and understand the relationship between this intentional use of cannabis and the frequency of crack cocaine use. And indeed, in our statistical model that controlled for a number of socio-demographic and other drug-using characteristics, we found that those after periods were 89% more likely to be less than the before periods. They were associated with reductions in the frequency of crack use. And indeed, and among 25% of the individuals who reported the intentional use of cannabis for crack, those individuals reported that they had ceased using crack altogether. Now, obviously, this is an observational study. We cannot conclude that it was cannabis at the root of these apparent declines in the frequency of crack cocaine use. And indeed, what I think is maybe the most notable thing about this study was that individuals were reporting that they had an intentional strategy to use cannabis in this regard. We started collecting this data in 2012, 2013. There was certainly no media exposure around cannabis substitution. There were certainly no healthcare providers saying to them, hey, why don't you try using cannabis instead of crack cocaine? This was an entirely ad hoc strategy developed apparently among these individuals, which in our statistical model was associated with declines, but I think is notable for their use of crack cocaine in this setting. So we wanted to investigate sort of the use of cannabis, the intentional use of cannabis in the lives of these individuals. And so we engaged in a number of ethnographic qualitative interviews. We conducted these interviews among approximately 22 individuals from the street youth cohort, and we wanted to talk to them about what their experiences with trying to control or eliminate their use of injection drugs. And one of the themes that emerged was really around the use of cannabis during periods of withdrawal. And this, I think, is a very emblematic quote from one of the participants, a 27-year-old Indigenous woman who told us, being on drugs for such a long period of time is like, that's how you're normal. And now when I stopped using, like I'm still having a hard time adjusting. It's really hard to deal with, and that's why I started smoking weed. So this testimony from this individual was, as I said, very emblematic and really tried to teach us, I think, about the role that many of the individuals in our studies have ascribed to cannabis. And individuals try to use cannabis as part of their drug use strategies, not only to maybe address some of the reasons why they're using drugs in the first place, but also to manage their drug use itself. And so this individual, her testimony is quite evocative of others who told us that especially in periods of withdrawal, when they're trying to cope with the rigors of stimulant use and trying to cut down after binges and runs of stimulant use, cannabis was very effective or very helpful for them. Of course, we all know about the gateway theory. I survived exposure to the gateway hypothesis in grade 8 when the local Mountie came to our gym class and told us that people who would use cannabis would necessarily go on to become heroin and crack cocaine users. Fortunately, of course, that viewpoint is not necessarily grounded in science. And as we all know, that there are an increasing number of studies which have cast doubt on the gateway hypothesis, and even studies which are beginning to suggest that cannabis for some people might be part of an exit strategy, especially around opioids. Again, with the street use cohort, we were interested in seeing what impact cannabis might have on patterns of injection drug use. We have heard from some individuals who were using drugs that cannabis was associated with declines in drug use. We, of course, were also very interested if cannabis might be contributing to increased frequency or intensity or increased risky routes of administration among people who are using drugs. So in this epidemiologic study, what we did is we restricted our data set to approximately 400 individuals from the street youth cohort who at baseline, at the first interview, told us that they had yet to start injecting drugs. And then in a survival model, what we did is we looked at the relationship between periods of frequent cannabis use and the likelihood or the hazard of them initiating injection drug use. And rather than cannabis being a risk factor for progressing from non-injection to injection drug use, what we found, in fact, was the reverse. In a statistical model adjusted for many risk factors for initiation, we found, in fact, that frequent cannabis use was associated with slower rates of initiating in drug use. And in fact, the relative hazard was approximately 34% lower than 1. Again, this is an observational study. This is correlational data. And so I do not want to suggest that what we are seeing is some sort of causal mechanism. However, I think it is interesting that certainly viewed in the context of our previous findings, there may be some weight to the idea that individuals are using cannabis as a way of trying to control their drug use and trying to ensure that it is not riskier drug use than they are comfortable with. Turning more to a bit more of a clinical study, clinicians in the room who provide care for people with opioid use disorder will know that the literature around cannabis and opioid agonist therapy is relatively inconclusive. A number of studies, in fact, have found that cannabis is a risk factor for poorer engagement in opioid agonist therapy, in particular methadone, whereas some other studies have found the reverse, in fact, that cannabis helps people stay on methadone treatment. What we did is we looked at our longitudinal data set to try and understand the possible impacts of cannabis on people beginning opioid agonist therapy in our setting. And what we found among 810 individuals with beginning methadone for the first time, we found that individuals who told us that when they began methadone, they were using cannabis at least once a day, they were 21% more likely to still be on treatment 6 months later. This is a tremendously positive finding, especially in the context of the overdose crisis. Because, of course, engaging individuals on opioid agonist therapy remains the best way that clinical science has to lower the risks of opioid overdose, lower the risks of mortality, and lower the risks of HIV acquisition or disease progression. We're not sure why our findings are positive, whereas other studies have found negative associations between cannabis and methadone engagement. We hypothesize, and this has been borne out by some of the clinical members of our team, that in Vancouver, it is like in other settings, people on methadone are typically forced to provide a urine drug screen. However, in Vancouver, individuals with THC positive drug screens are typically not removed from methadone therapy. However, in other settings, evidence of continued illicit drug use, including THC exposure, is taken as grounds for removing people from methadone therapy. So we hypothesize that that might be some of the difference. That in Vancouver, clinicians are much more accepting of co-occurring cannabis use alongside methadone, and so there is not that sort of structural risk of disengagement. However, we are very interested in subsequent studies that we are doing now to try and understand the possible role and the possible benefits of cannabis use during methadone treatment in terms of quality of life, in terms of pain, and in terms of coping with withdrawal. One of our more recent studies looks more directly at the question of overdose, and in particular looks at exposure to fentanyl. As I mentioned, fentanyl is really the driving proximate factor behind the number of unprecedented deaths that we've seen in our setting. And the sad reality is that fentanyl really has infiltrated the entirety of the illicit drug supply in Vancouver, not only opioids, as you might expect, but of course stimulants, including methamphetamine, crack, and powder cocaine. And many individuals, in fact, individuals that used to work on our study team, have died from fentanyl overdoses despite not consuming, to their knowledge, opioids, having smoked crack cocaine. So understanding patterns of exposure to fentanyl is very important in our setting, and I would argue in others. So as I mentioned, in 2015, we began to gather urine drug screens from our participants. And this study really looks at the first bit of results from those studies. We included data from approximately 650 individuals, and these are individuals from all the cohorts, so HIV negative, HIV positive, and street youth. And what we found was that for individuals, if they had a fentanyl positive screen, they were far less likely to have a THC positive screen. So there was a negative association between being exposed to fentanyl and being exposed and using THC or being exposed to THC. Again, correlational and observational, and we're not really sure why this might be so. A couple of things to suggest. One, despite recent pronouncements from our friends in the Trump administration, there are no verified reports of fentanyl being found contaminating cannabis bought at the street. There has been a number of, it is at this point, I would argue, a bit of an urban legend that individuals are cutting cannabis with fentanyl. However, our colleagues in the RCMP and other police forces have repeatedly assured us that this has not been the case. These findings, of course, are also consistent with the substitution hypothesis, that individuals are trying to use cannabis and by doing so, they are lowering their risk of exposure to opioids. But again, this is correlational data that we need to do more to analyze to understand what kind of causal mechanisms, if any, underline our results. The final results are really the closest we're getting to determining or to describing an individual level relationship between cannabis and overdose in our setting. This study is under review. Please cross all your fingers that it survives and will soon be appearing in public because I think what it says is quite important. What we did is we looked at the likelihood of self-reported non-fatal overdose longitudinally using data from approximately 3,000 interviews gathered from almost 1,400 people who use drugs during the current overdose crisis in the city of Vancouver. And what we found in the final model is that individuals who told us they were using cannabis at least once a day had approximately 33% reduced odds of having a non-fatal overdose. And I think what's really notable about this model is that it's adjusted for all of the other risk factors for overdose in our setting. So what this is saying is that even if you are younger, you are homeless, you are using illicit prescription opioids at least once a day, you're using heroin and methamphetamine, and you've been exposed to the criminal justice system. Even if you carry all those risk factors, you still have a lower risk of overdose if you are using cannabis. Again, observational, correlational, we cannot conclude that there is some sort of causal effect here. But this, I think, is, to my knowledge, the first real individual level evidence describing a beneficial relationship between cannabis use and overdose among people at the highest risk of overdose. So, before I try and sum up, I do want to sort of go through the limitations so that we can really accurately discuss the findings that I've showed. This is observational data. These cohorts are not randomly recruited, so we cannot conclude that they're representative of groups of people who use drugs in other settings. A lot of the drug use data, including the cannabis use data, most of it is self-reported. And so obviously there are problems around recall. I can't remember what I had for lunch yesterday, so asking people what they had and what their cannabis use patterns were 6 months ago is obviously subject to recall bias. As well, of course, these are criminalized activities, and so there are the risks of social desirability bias. However, we have been working with these individuals for, in some cases, up to 20 years, and I would suggest that we have relatively good and trusting relationships with them. The urine drug screens, the time of detection is different for different drugs, so there may be some problems there. And perhaps most importantly, as other speakers have noted, there really is no such thing as cannabis. Talking about cannabis is like talking about wine, in that it really obscures many of the important differences between the different things which individuals may be exposing themselves to. Only recently have we begun to gather data on some of these important factors, including what type of cannabis they're using, what the relative concentration of THC and CBD might be, what their route of administration is, and what their dose and dosage is. All of these things will be very important, I would argue, as we move from sort of observational studies to experimental studies and to try and replicate these beneficial effects in clinical or experimental settings. So, what's going on? How can we explain these apparent beneficial associations between cannabis use and drug-related harms? The first is obviously some sort of error or some sort of unmeasured confounding. Maybe cannabis is in fact a proxy marker for some sort of latent factor. Maybe folks who are using cannabis have lower intensity drug addiction patterns. Maybe they have different socioeconomic backgrounds. These are the sort of the hypothesized confounding factors. This is possible, and we cannot exclude it given the fact that we're using observational data. However, I would point out that many of our, all of our statistical models are adjusted for many of these confounding factors. The other two hypotheses, of course, suggest that there is some causality at work here. Maybe individuals in this cohort, at least some of them, are using cannabis instead of higher risk drug use. And obviously when it comes to overdose, the risks of overdose associated with heroin and cannabis are obviously radically different. Maybe, in fact, cannabis also addresses some of the reasons why individuals began to use illicit drugs and continue to use illicit drugs at the same time in terms of addiction, dependence, or indeed the comorbidities that often go along with drug use. These are some of the hypotheses that we will work to try and investigate in the years ahead. But I think clearly the findings that we've gathered so far really do support the fact that we need to move, especially because we're in a public health crisis, from simply observing things to trying to manipulate things through experimental trials to try and see if cannabis-based interventions are indeed effective at reducing rates of overdose or drug-related harms in this very challenging population. I'm not a clinical trialist by training, so many of the things that we are now dealing with in terms of trying to put these trials together are quite challenging. And some of the challenges, of course, are challenges common to all clinical trials. What would be the best outcome of interest? What's the most appropriate study design given our research question? But the last two, I would argue, are indeed specific or common to all sort of cannabis-related trials. What kind of study agent would we use? What would be acceptable to individuals in the community? What kind of cannabis do they want to be using? And maybe more challengingly, more difficultly, how can we maintain our study integrity given the fact that cannabis is available very widespread throughout the community, and indeed legal cannabis is now available to individuals in Vancouver at least, and other parts of Canada. So there are a number of methodological challenges here as we go about trying to design clinical trials to try and replicate what we are seeing observationally. Fortunately, as you probably know, in the HIV world, in the drug world, in the cannabis world, people in the communities, the members of the affected communities that we work with, the populations of interest, are not waiting for us to figure out these sort of challenges before moving forward. And I'm certainly, I think we're all very grateful to that. And in Vancouver, in fact, there are currently two low barrier community-led efforts to distribute cannabis to people at risk of overdose. One of them is called the Cannabis Substitution Project. Activists are distributing every Saturday care packages, as they call them, to people, anyone who comes out of the offices of a local drug user advocacy organization. They give them edibles, they give them joints, and these are primarily products that are donated to them through the illicit market. There is also the High Hopes Foundation, which wins my award for Best Pun of the Year, which distributes cannabis for free to clients using an overdose prevention site, which is a low barrier medical intervention where individuals can use drugs under medical supervision. They are also giving out products that they are being given through the illicit market. We are teaming up with them to perform an observational evaluation and as well to legalize their activities and hopefully allow them to accept donations from Canada's licensed producers. So Let me conclude. I think, the sort of the takeaways for me at least are that cannabis is certainly very common, right, among people who are using other drugs, who are at high risk of overdose. But despite this, and despite the fact that I think this is relatively universal observation, the effects and the impacts of cannabis on the health and well-being of these people has been relatively understudied. In our setting, we found in some preliminary results interesting associations between frequent cannabis use and a lower risk of some harms, including non-fatal overdose, exposure to fentanyl, starting to inject, and indeed we've also found cannabis associated with better engagement on the first-line therapy for opioid use disorder. All of these things, I would argue, have some implication with the ongoing overdose crisis. Perhaps most interestingly, we do know as well that many of the, or at least some of the individuals in our studies are using cannabis intentionally as a way of trying to protect their health and well-being. And I'm very interested in continuing to learn from these participants and to roll that into our experimental trials to see what we can do to try and exploit that knowledge, to test that knowledge and see if we can scale it up at a broader scale. And so that's what we're going to be doing in the next little while, our experimental trials to further explore the use of cannabis by this population in the hopes of adding another tool to address the public health catastrophe that is ongoing. Thank you very much.
Thank you very much, MJ, for your very nice presentation.
Thank you.
In Vancouver, was there